A 50-year-old woman is brought to the emergency department after an episode of syncope. The physician determines that the patient likely suffered a transient ischemic attack. Which of the following being disrupted most likely led to this patient's symptoms? Choice A, beta oxidation. Choice B, glycolysis. Choice C, Cori cycle. Choice D, oxidative phosphorylation. Or choice E, aquaporin channels. I'll wait 5 seconds and answer the question. This might seem like a strangely simple question, but I based it off a similar NBME question, and sometimes you'll get questions like this where you kind of feel like, is that it? And also it's another case of USMLE probably playing medical thesaurus with you, or I guess in this case, biochemistry thesaurus. So this patient had a TIA, which is an acute hypoxic injury. So first, as a note, you want to know that there are certain tissues in the body especially susceptible to hypoxic injury. Obviously, most of your tissues don't like hypoxia, but especially your brain, your heart, and your kidneys, especially the proximal convoluted tubule, can quickly be injured or disrupted in a hypoxic state. And of course, on the biochemistry end, if you lack oxygen, you're mostly talking about the inability to perform aerobic respiration, which of course ends with the electron transport chain, aka choice D, oxidative phosphorylation. Now, just to go back real quick and re-emphasize, I mentioned the PCT of the kidneys being highly susceptible to hypoxic injury. I've talked about this in other videos before, but it's a point that comes up pretty often in the NBMEs, that they want you to know that the PCT is very susceptible to hypoxic injury, and that could be from ischemia, it could be from just like an acute hypotensive crisis or something, or from blood loss during a surgery. So they can give you really generic questions like something like, oh, a patient had surgery and all of a sudden they have oliguria, or their urine output decreased. The implication being that the blood loss or the hypotension that might have happened during surgery damaged their PCT. And this, of course, is because of the large amounts of sodium-potassium pumps in the PCT that are reliant on generating large amounts of ATP, which of course is also related to oxidative phosphorylation, electron transport chain. You need oxygen to make that run. So let's look at some of the wrong answer choices here. Choice A, beta oxidation. This is the method through which fatty acids are catabolized in the body. Now, some of you might have picked this because you thought, well, beta oxidation also requires oxygen. But aside from the fact that beta oxidation really should not be your first thought during acute hypoxic injury, we're also talking about the brain here, which does not typically undergo beta oxidation because the brain doesn't use fatty acids for energy, and fatty acids can't cross the blood-brain barrier. Beta oxidation I would more associate it with the liver, hepatocytes, myocytes, muscles, and adipocytes, of course. Choice B, glycolysis. I mean, glycolysis is anaerobic. Obviously, the relevance here is that you would be relying on glycolysis in ischemia, but usually glycolysis alone cannot keep up with the ATP demands of our tissues. And of course, the pyruvate that you generate from glycolysis in a hypoxic state would eventually get pushed towards making a bunch of lactate, since you can't use the TCA cycle as much. And that's actually somewhat related to choice C, Cori cycle. The Cori cycle is basically a cycle for lactic acid. When lactate is produced by the muscles during exercise, or just whatever necessity, it can be transported over to the liver to be converted back into glucose via gluconeogenesis. Cori cycle is important for reducing the odds of lactic acidosis, and it's not really relevant to hypoxic injury of the brain. Choice C, aquaporin channels, is just a distractor I came up with. Obviously, aquaporin is involved in all kinds of water transport and equilibrium across many different tissues. Of course, aquaporin appears in places like the collecting ducts of the kidneys. Of course, it's on neurons as well. And for that specifically, you could probably think about things like central pontine myelinolysis, which doesn't result from a problem with aquaporin specifically. It's more that you corrected hyponatremia too quickly, and that causes water to be pulled out of the neurons, which will cause all kinds of nasty effects, including demyelination, and it can cause severe long-term damage to the neurons. So please don't do that. Don't correct patient sodium balance too rapidly. Another relevant condition with aquaporin is probably neuromyelitis optica. Very low yield, very rare autoimmune disease that has shown up once or twice, I think, on USMLE. It's believed that autoantibodies against aquaporin 4 eventually can cause damage to the optic nerve in the spinal cord. So when they present it to you in a question, it can sound very similar to multiple sclerosis, but a lot of the studies will not be similar to MS. You won't have the elevated IgG index or oligoclonal bands. Like I said, it's kind of weird, but it's just a rare condition that's come up before. So bring it back. Major things you want to take away from this question are: what are the tissues most susceptible to hypoxic injury? Your brain, your heart, your kidneys, especially the PCT of the kidneys. And you just got to remember some of these annoying terms from your undergrad that you might have forgotten. Oxidative phosphorylation, that's just electron transport chain. Sometimes I like you connecting it back to your basic biochemistry knowledge. I hope you found this video helpful. I'll see you in the next one.